So the topic that I'm going to discuss with you is one of the newer methods of imaging on how we can look at the function of the spinal cord rather than the anatomy of the spinal cord. Now we all know that the spinal cord is a highway of neural information, and for anybody who's dealing with a spinal cord pathology, whether it be a gross deformity or a spinal cord injury or a chronic compressive scenario like the myelopathy, the actual physiology and functional status of the cord is of paramount importance. Now, MRI has become the gold standard of assessment of a spinal cord. But however, MRI shows the anatomy and the physical state of the cord, but it does not actually show the functional status. For example, here you can see that the one that is having the least compression on the MRI sometimes can present with the most severe neurological problem. And sometimes we can see gross compression, but the patient is functionally intact. So this has been also discussed very widely in the literature, where people have found that there is sometimes very poor correlation or no correlation at all between the signal intensity changes that you see in the MRI and the neurological status over here. Even in case of injury, you will find that the MRI shows that there is a mild spinal cord damage, severe and moderate. But actually when you see the clinical status, it can be completely different. So why is this difference? Why is there no correlation between the physical state of the MRI and the functional status? I think we can look at it logically with the analogy of an electrical wire. Now the electrical wire has got many smaller fibers inside, and actually the MRI looks at it from the outside, but the status of the individual wires inside, whether they are intact or they are completely gone, is not very clearly shown by MRI. So the question is there a better way of looking more into the cord than from outside? And here, diffusion tensor imaging may be the answer. The real application of diffusion tensor imaging came in the brain, where rather than seeing from outside, the ordinary MRI looks at it like this, but the DTI actually looks at the individual fibers in the brain. And there are now well-established technology in the brain, and this is very well reported in many diseases. Now, what is the difference between DTI and MRI? Now, we have to look at the physiology of physical basis of MRI. Now, we know that all revolving objects have a magnetic moment, and each proton in the body has a continuous rotation over here. But all these are rotating in different axes. So there is no net magnetic potential in the body. When you give a magnetic impulse, now all of them become linear to one axis, and when the pulse is taken off, they all go back to this. And this magnetic dance is what we call as the magnetic resonance, and this is used to get your impulse for MRI. So if you have a brain like this, you can see actually you're looking at the proton content and the amount of tissue fluid over there, and it gives like this. But if you have to go to the next stage of looking at the fiber, you need to go one step ahead. So DTI not only sees protons, which is the water molecule, but also assesses their mobility in the tissues. Now we all know in our physics, we have read that every single live particle has got a random incoherent movement called the Brownian movement. Now this occurs everywhere. Now if it is a sphere, these moves in all directions, and the movement on all axes is just the same if you take it from the center, and so it is called isotropic diffusion. But if the cavity or the content is a cylinder, then you will find that the movement in certain direction and molecular movement is preferential in the longitudinal axis, and that is called anisotropic diffusion. And so your axis in which the way that it moves is quite different. Now if it is a thick cylinder, then of course the movement is going to be like this. Thinner, it becomes more on one direction, and if it is a very thin cylinder, then the movement becomes more on one single direction. So your E1 vector is going to be completely more than your E2 and E3 vector over here. Now the DTI software looks at the axon, which is a thin cylinder, and it converts it into many different small voxels. Voxel is the three-dimensional representation of a pixel, and it finds the movement of these molecules and then traces it across the axon, so that you get a beautiful picture like this. You not only see the cord, but you also see the individual fibers within the spinal cord, which is very good. Now here you can see that this is what you get by getting, and you can do a three-dimensional vision of the spinal cord over here, and you can get a very good movement if the spinal cord is intact. Now if you have any disruption over the spinal cord, then you will get a different motion over here. So the equivalent of this is that if everything is intact, then you get a picture like this. Now if you have a disruption of the individual fibers inside, then you get a picture like that. So you have a very pictorial representation of the disruption of the tracts. Now what is very good is that the vectors can be color coded. Now whatever is from left to right, the fibers can be color coded as red. The superior to inferior is color coded as blue, and green is anterior-posterior. The spinal cord is entirely from top to bottom, so the whole spine always appears like blue. But if you see the brain, you can see that there is a huge amount of different colors over there, and the distortion of these in different things like a brain abscess over here is very well clearly seen. Our first interest in diffusion was when we had a patient of scoliosis, and we found that he had a horizontal gaze palsy. And when we read in literature that they have some problems in the brain tracts, we tried to do brain DTI, and here you can find that in this patient, you see that there is no cross connection of fibers at the level of pons, whereas in the normal individuals there are cross connections in the level of pons, and we were able to demonstrate it very clearly. That increased our interest in DTI. So we went ahead to find in a spinal cord model of the calf, and here we got all the exact protocols correct in the animal studies, and then we were able to do here over clearly. Here you can find that on a cursory view, you may find that there is no major difference between these two. But we have done a stab incision over here, and you can see that there is a hemisection of the cord that we have created at the top. But if you do a DTI, you can see that there is a dramatic change, that you can see that the fibers are completely blocked over there. So between this and this, you find that there is a major difference, because you can see the disruption very well over here. Now this is, you can see, if you extend the section more, it clearly shows that almost there is a complete disruption of fibers over that region. Now you can, in big lesions, you can put a seed point below and above, and then you can actually get the block in that direction over there also very clearly. Now what does it do in actual life? You can see that we had a C6 burst fracture, incomplete neurological deficit, but you can find that there is a block over there. And if you put a seed point below, you can see, if you see a continuation, then you know that these patients will completely recover. Now we have found this, and we are documenting it in about 30 patients being followed over the period of 2 years. So on day one itself, it may be possible that for us to get a good prognostic imaging. Now this is a case we reported in the Journal of MRI, that this patient reported to us with a stab injury, and he had complete paraplegia when he on presentation. And this was the appearance of in the MRI on presentation, and you can see that there is a lot of edema. But when we did a DTI for him, it showed that there was only a partial cut of the fibers, and some of the fibers were intact. And sure enough, in 3 months' time, he recovered partially to have a complete Brown-Sequard syndrome. So even on day one, even when the patient had a complete spinal shock and when he had a problem, we were able to predict that part of the spinal cord was still intact. So here again you can see in a spinal tuberculosis, a patient who came with gross neurological deficit, but the tracts were intact and they completely recovered few over here. Now the tractography alone is not important, because you get in a chronic compression, you can get quite severe distortion of the tracts over here. So you get what is called the datametrics, which means you can actually find out how much is the vectors by which this moves. And there are two important vectors, the fractional anisotropy, which shows whether the axon is a perfect cylinder or not, and the apparent diffusion coefficient. I'm not just going into it for more confusion, but these are two important vectors, datametrics, which shows us what is the thinness of the cylinder, and the other one shows whether the cylinder is intact, so that the fibers are not diffusing out of the cylinder. Now you find here that in the first study we did in spinal cord injury, you can find that wherever there is an injury, there is a complete dip. And we were also able to show that these patients had the same maintained dip in patients who did not fully recover. Now, we also found it has additional values in cervical spondylotic myelopathy also. Now, in this patient, you can find that this was the most significant compressive level in plain MRI, but Datametrics showed that there was actually more functional disturbance at C5-6 because the dip in the Datametrics is much more here. So that gave us an additional clue that a single level decompression here is not sufficient, and probably this patient requires a multiple level decompression. So does it reverse with decompression? You can see that this was the preoperative level. As the patient improves, the Datametrics also improves, and at 6 months, when the function of the patient was very good, it had also worked. Now lastly, there are some limitations on which we are working, because the spinal cord in comparison to the brain is of very small size, and it is highly susceptible to motion because the patient has to be without swallowing during the entire period of data acquisition, and also the heartbeat, with every heartbeat there is some CS of motion in the cervical cord. So these are some things which we have to overcome, and we are doing a prospective study of getting the best protocol to do. But in the long run, I think it also needs bench to bedside translation, and we have to actually find out whether in the long term the Datametrics are proved to be a good prognostic indicator. But overall, the DTA is a big jump in our evaluation of pathology, whereas from we were previously looking at the cord level, it will allow us to look at the tract level. Thank you very much for your. I think we will have all the questions at the end, and can I request now Professor Keith Look to deliver his talk on